lined up for you today. So as I say, welcome everybody to this latest webinar in the Social Prescribing Link Worker webinar series that we're hosting at NASP. This is the sixth one that we've done this year. I can't quite believe that we've gone through that many. It's been a really interesting and insightful series. So thank you to everybody for their engagement. This particular webinar is on making outcomes meaningful, and we're going to be talking about how we can better understand the importance of data capture, how to collect it, and how we can make sure that our work is demonstrated as meaningful in the social prescribing ecosystem. So before we get going, I'm just going to go through a little bit of housekeeping for us. Those of you that have been to the last 6 webinars will likely be able to recite this alongside with me. But if we can go to the next slide, then I can go through the housekeeping. So we are recording this webinar. So all slides and that recording will be sent to anybody that has signed up to this webinar. It will also be on NASP's website. So you can share this with others that you think might be interested in this topic afterwards. We're going to be using the Q&A function on Zoom for the question and answers that we'll be coming to at the end of the webinar. So please use that function to put any questions to any of our speakers throughout the presentations. The chat function is the space to network, to get to know each other. So please do introduce yourself. And it's also the place to raise if you've got any technical issues or any problems with sound, etc. Raise those in the chat, and we've got people working in the background to support with those if we can. Closed captions are also available. So please do turn these on at the bottom of the screen if that makes this webinar more accessible for you. And also, as this is a sort of learning webinar, we're all bringing our own different experiences and viewpoints into this space today. So let's keep an open mind and really use this space to learn from one another and also the speakers as well. So the order of the day, if we can go to the next slide, is I will be chairing this webinar. So I'm Monica Bolton. I'm the strategic lead for healthcare integration and neighbourhood health here at NASP. We'll then be hearing from Sarah, from Jag, from Nikki and Tara, who all bring really different perspectives to this specific topic and a really sort of well-rounded overview of how we can make outcomes meaningful. And this is a topic that has come up time and time again that is of interest, both interest to link workers, but also of really high importance among the workforce. And we know through our social prescribing link worker survey that outcome data collection is not something that is being consistently embedded within practice. However, it is so vitally important as we continue to make the case for social prescribing, as well as demonstrate the really meaningful impact that social prescribing link workers are having. We know that one of the barriers to that outcome collection is link workers reporting that they need more time to be able to do it effectively, that clearer processes are needed, but also better systems are there to support that more consistent data capture. And as systems are being encouraged to move away from not just measuring inputs and activity, but focusing on those meaningful outcomes that really support us to have that population health management approach. It feels like this conversation is particularly timely at the moment to ensure that link workers are really demonstrating the difference that they are making in a way that matters, not just to people that might be able to receive that feedback, but also to our commissioners and to the wider system that might have an interest in how social prescribing can be effectively used. Now, of course, data can be used for service improvements. It can be used to support clients to receive kind of input on what their progress might be looking. But it's also a really key way to demonstrate the value of the work that you're doing, both at that local scale, but also that national scale. So we're hoping to bring that into the conversation today. Now, we appreciate that because some of those barriers that I alluded to earlier, the fragmented IT landscape, the inconsistency in access to certain systems such as EMIS or System 1, that's not something that we can solve on this call, of course, but obviously must be recognised and named as some of those barriers that we face. So we're not looking for the sort of perfect answer and perfect response in today, just a hope that this webinar will really help you to consider how you might be able to better collect meaningful outcomes. And so I'm really looking forward to hearing from the speakers today who, as I say, bring a real variety of different perspectives and experience in this space. So really looking forward to hearing from each of those. So without further ado, enough from me. We're going to hand over to Sarah first of all. So Sarah Penn has led a social prescribing infrastructure project for 2 years. And this has included management of a system-wide steering group. And that's all been based in North Cumbria. This has culminated in the publication of a cross-sector report, which is absolutely fantastic. There's a QR code in her presentation, so you can download it. I really encourage you to read it. It's called Passion, Connection and Community, Person-Centered Neighbourhood Health in North Cumbria, and that was only launched last month, so hot off the press. And this includes referral data, case studies, and a bespoke evidence review. So looking forward to hearing more about your approach today, Sarah, on this really important topic. Over to you.
Thank you, Monica. So as Monica said, Sarah Penn, and I am Health Partnership Support Officer at Cumbria Council for Voluntary Service. And for 2 years, my role was funded through the health system to really improve the infrastructure and the connectivity around social prescribing. So to link the link workers up with each other, to link them into the third sector, so that what they were doing was more meaningful, and we were avoiding duplication, offering choice, linking between services, and really encouraging partnership. One of the things that we were able to do as a result of taking on management of that social prescribing steering group, which Monica mentioned, was really build a kind of collaborative consensus. We brought in lots of different people, and I think it was one of the benefits of having that housed in the third sector rather than having it embedded in the formal structure of an ICB or a local authority. It meant we were able to bring together that kind of collaborative consensus of really what we wanted to do, how we wanted to tell the story of the impact that social prescribing was having in our communities. And North Cumbria is a very large area. It's an area with different local authorities. We have a whole variety of different approaches to social prescribing, and we wanted to take a really broad view of that, but equally be able to bring together some key parts of that data. So as Monica mentioned, that report was really about, given all the barriers that she just talked about those different data systems, those different systems, different organizations, different roles, different outcome measures, different consistencies in terms of how they were measuring what their activity was. Could we do something that was meaningful, even if it was imperfect? So you'll see the final report. You'll be able to see if you scan that QR code, and I'm sure they'll send around a link as well. What we wanted to do was, yes, we wanted to have some numerical data in there, but what we also knew was that numerical data was not consistent across our system. It wasn't collected in a particularly reliable way in the biggest part of that system, in the primary care networks. There was a lot of variation and inconsistency in terms of how people were recording that. But what we really knew that hit home and told the story was that person-centered approach to telling the story, case studies, being able to hear from somebody who lives in your community, who's been helped to engage with activities, and how that has really transformed their lives. And those case studies were I suppose the highlight of that report, the beating heart of it, and those are what I think draws people in. So what we found through that steering group was that we could just about bring together referral data coming into the different parts of the system. So referrals kind of taken up or people accepted into those services, and then the level of intervention given, whether it was a long-term kind of 6-month health coaching type intervention or a much shorter signposting or supported signposting intervention. And I suppose what we came to was that however we collated that data, it wasn't perfect. We, as a process of collating it, we did take this, like it says there, a pragmatist, realist, and very imperfect approach. So we knew that it wasn't gold standard data. We knew that that we couldn't evidence impact and outcome on a numerical system-wide level. But what we did do in those case studies, that's where we showed that impact and those outcomes. And in terms of bringing in the research, we didn't. In some ways, it feels unfair. It feels like social prescribers, they have to prove the evidence base for what they're doing every single time they're in talking to whoever's commissioning them, which we don't expect of other healthcare workers, other healthcare interventions. The evidence is there. The evidence is there in literature. And so we wanted to kind of really bring that in, really make it like relevant and talk to the people here in North Cumbria, so that they could feel confident that this was an evidence-based approach. The stories of the people here have that real connection to the locality, and then we have some that data in terms of the referral data to paint a numerical picture of what's happening here. Next slide, please. And yeah, as I briefly alluded to there, the actual act of collating and collecting this data had a really powerful impact on the quality of that data as we moved into the future. So the link workers in the primary care networks, especially, they had often no access to the data that was being recorded and that was being shared to people that weren't them, and wasn't being used for any particular purpose. It was collated, it was sent somewhere, nobody looked at it, nobody told them about it. So they didn't have that ownership of that data, which then has an obvious knock-on effect on the likelihood that they're going to consistently record that. Why would you record something that feels like it disappears into the ether, never to be seen again? You can't use it to make your case for why your role is important. So we had several sessions where we looked at the code, like the technical stuff, the codes, the templates that people were using in EMIS, when they would be ticking certain boxes. We looked at when there might be potential double recording. So when the box was being ticked at the point of referral and at the point of accepting the referral. So some of the more technical bits like that. And trying to find whether there was a proxy measure for that kind of level of intervention that we were talking about. So it was this iterative process where we knew that the data wasn't perfect, but simply by collecting it, and reflecting it back to those people, they could then see that their data had some purpose, that it could form part of this patchwork. That also includes those human stories and the robust research evidence, and combine that all together to really tell a powerful story of the impact and the transformative effect on people's lives. And the last point on there, numbers need humans to be meaningful. So both in terms of those case studies, but also this was an intense relational process creating this report and accessing people's data. There are a lot of kind of barriers in terms of people's willingness to be part of this collation, to be seen alongside other services that they perhaps didn't recognize as doing similar things to them. A lot of kind of human relationship work that was needed to bring people together, to make that data meaningful, and to help those link workers especially feel that their data mattered. If you move on, I'm not sure if I've got another slide or not. So yeah, I think it's what it is an example of what can be achieved in this incredibly imperfect world that we have. Yes, it would be great if we had a standardized outcome measure. It would be great if the systems all talked to each other. It would be great if everybody knew what we meant when we said social prescribing and that it always meant the same thing. But that is not what we have in this world. And so what you will see if you look at this report is what can be achieved without that level of consistency, and how you don't need one piece of data to do everything. You can stitch it together and build it together to form this beautiful patchwork of what social prescribing is and does. That's
Thank you
me.
so much, Sarah. I mean, it's just been, such a joy to kind of follow this piece of work and actually see it kind of be brought to life is just really, really encouraging. And I particularly like that broad lens approach that you have taken, which has allowed you to bring some of that imperfect data together to do that storytelling. And as you referenced, there is lots of evidence out there to say that social prescribing works or similar interventions work, but sometimes that evidence might need narrative to accompany it. And that's exactly what this report does by using both quantitative and qualitative data. So a really encouraging piece of progress to have seen in North Cumbria, and congratulations again on that report. It's great to hear a little bit more about it today. Thank you. Do
Thank you.
put any questions that you might have for Sarah into the chat, and we will come to those at the end. But for now, I'm going to hand over to Jag. So Jag is a decision scientist specializing in the use of real world data, pragmatic evaluation and innovation to design high return on investment interventions and scale integrated preventative models of care. He's supported and led over 200 initiatives shaping national frameworks and evaluation approaches for population health and prevention across primary and community care, which is of huge importance and value to NASP. So it's been great working with Jag over the last couple of years. Jag, over to you.
Thanks, Monica, and thanks for the introduction as well. So I think basically, in my own words, I'm an analyst supporting NASP with data and evaluation to help move money towards good things, to put simply. And today I just want to talk about three things. The first is I want to talk about a kind of I don't want to use the word logic model because it makes it sound too fancy, but just a set of sensible steps that we think happen in order to take small bits of work all the way to good things happening for people and good things happening for systems. So I want to talk about a logic model. The second thing I want to talk about are two questions you can ask the people you're supporting, the patients and the citizens you're supporting, to help show benefit to them, but also benefit to systems in economic terms. And then the third and final thing I want to talk about is how you show that data to help convince people to give you some cash. Could I get the next slide, please? And please, just ask questions all the way through, and I'll try to keep an eye on them and also answer them at the end if needed as well. Yeah, so the first thing, so what's the logic model that we are working to that contextualizes social prescribing? So in terms of, when you call it prevention, integrated care, neighborhood health, the NHS more generally, or just what makes sense to us as regular human beings, these four steps are what we're all working to in order to kind of do the things that we want to do the things that we feel are right. And so what they are effectively are, first, if we want something good to happen, first somebody needs to start doing it. That's activity. Then their behavior will change or improve. And then later their health will improve. And then after that, their demand will reduce. So for something like social prescribing, it really makes sense to find out or capture some information on both activity and behavior and use that information to tell a story about health improvement that might or could happen, or demand improvement that could happen based on those behavior change metrics. And that just makes the whole evaluation exercise much, much easier if you can do that. I'll just step through each box in a little bit more detail. So let's say, for example, if you're recommending a intervention, or you're offering social prescribing to people, and a very, very small number of people want to take it up or go to that intervention. If it were a product on a supermarket shelf, you would say something is up. Something is up with the group who's being reached out to, the engagement approach itself, and or the product. So generally speaking, if less than 20%, or probably less than 10% is probably a bit fairer, of people take up an offer or do a thing, that's giving you a signal that the thing and the way you're introducing it or offering it to people isn't right, or it could improve. And this is just an often missed number that we just fail to collect. So for social prescribing, that number would probably look like in two ways. It'd look like how many people being offered social prescribing are taking it up, and could it change the offer and the engagement approach? And then it also applies to the interventions you're referring people to. If lots of people are offered something and they don't take it up, it's a time to review it. And that threshold is about 20%. So after activity behavior changes, and this is where I'll spend a bit of time with some of on the next couple of slides talking about what some of these behavior change metrics are. But very key is how able somebody feels to take care of their own health and well-being, and that's patient activation. But also the pillars for health around mood and diet and activity and loneliness also count. And you want to see about a 10% change in these kinds of things. Then let's say after the 6-month point, then you might see BMI change, or HbA1c, which is diabetes control, or blood pressure change. And good is about kind of over 7%. And then much later still, and this requires more complex analysis, you might see GP visits and outpatients and admissions change. And that's considering what good looks like, is about 5% or more change in those kinds of things. So the final thing to say on this slide is the aim here is to learn in months, or weeks or months, about whether what you're doing is working or not, rather than waiting a year and not really knowing because there's nobody doing this evaluation for you. So my job is to kind of make this as simple as possible so it feels easy to do. So could I get the next slide, please? So on the second of my objectives today is to introduce two simple questions that let you do that cycle. So the first one is a patient activation or citizen activation question. And this can be worded in lots of ways. You might have seen me present on this before, talking about a question that's how good are you at taking care of your health? As part of the neighborhood health program, they're using a health confidence question, which is how confident are you managing your health? And so it doesn't really matter which one you use, both are roughly the same thing. What we're trying to capture here is my ability and confidence. So not just confidence, my ability and confidence managing my own health. And you can ask this question to the people you're supporting in any way you choose. It doesn't have to be kind of didactic and like a data capture. You can run it into a conversation. You can change the question. If somebody's giving you one answer, but you don't feel that they're at that stage, you can challenge them. So it's really there as a conversational support, something you want to ask because it's useful rather than a data capture. But ultimately, it lets one practitioner, a single question lets any role talk about activation and capture it routinely. In Calderdale, nobody was capturing anything for a long time. And then when we used this question, social prescribers started capturing this data in 1 in 2 contacts. So it went from nothing to about 50% overnight. And all the social prescribers there just found the question really useful. They found it a useful tool, a useful nudge, a useful for triage, and as I'll show you, hopefully useful for measurement as well. So let's say, for example, the time you spend with somebody is you count it in hours, and then you can convert those hours to pounds. So let's say you spend £50 worth of time helping somebody improve their activation from 1 point from not at all to not very. Let's see, you ask them the question at the beginning, I'm not at all able to take care of my health, and you help them and they move to not very, so they jump 1 point. We know that that saves, or that's likely to save, about 4 GP contacts or about £327 in an overall NHS demand. So if you spent 50 but saved 327, you've already taken a person reported outcome that matters to me, and you've currency converted it into something that matters to the system, all in one movement. And then the final thing to mention is that when you do it this way, you can generate really, really good cases for change and cases for investment, or at least start to, without very simple maths. But also, it makes demand reductions kind of more credible when activation improves. So if you're ever making a case for saving money in terms of healthcare utilization, but there hasn't been an activation change, it's just not very credible because you're thinking about, well, how long is this going to last? Could I get the next slide, please? So the second and final question I want to introduce is something called EQ-VAS. But this is another simple question, which is how good or bad is your health today? And this is a little bit more complex. And we've got a 1-page guide on how you can take the data from this question and turn it into health economics. And it might take a bit of time to absorb, and AI is a very good aid in helping to understand what's going on here as well. But ultimately, this question is dead easy to ask and answer, again, in contact or as a text message or something like that. And what this question lets you do, it can be used to estimate these things called QALYs, and they are quality adjusted life years. And that's essentially how much money it takes to, or costs to give one person 1 extra year of life in good health. So it sounds like quite a weird concept, but it's dead easy to calculate just from this one question asked before and after an intervention. Now, the benefit of this question compared to the other one is that this is a validated question, and it's part of the government's guidance on how to move money across anything in health. So this is what the NHS uses for everything, whether it's a surgical thing or a medical thing. So it really makes sense for social prescribing to capture the improvement or the cost benefit in the same way, because then we can really compete and or kind of compare against other NHS stuff. So it links the outcomes and cost effectiveness to value for money using the gold standard approach that the Treasury uses. And the threshold we want to aim to beat is £13,000 for a quality adjusted life year. So if you're helping people below this threshold, your intervention will be high value. Can I get the next slide, please? And then the final slide I want to show is the third thing, which is how do you show that information? And I've kind of implied it already. So the chart shows you, and this was for a movement-based intervention, how much it cost for RISE, which was a movement-based program for elderly people, to generate 1 year of high quality life, and it's about between £400 and £1,500. So as you can see, it's miles below the NHS threshold. It's 32 times lower than the NHS benchmark. And if you show that to somebody who holds the purse strings or a commissioner, it's really hard to ignore the data. You might not convince them, but they can't ignore you either, because you're so much more cost effective than what the NHS is currently spending money on. So showing the data in a visual way with a headline like that makes you really, really hard to turn away. And then the final slides I'll just skip through quickly are. There's lots of information here, but I'm sure we'll share the slides afterwards. This is just telling you that those 2 questions, they exist as part of the National Neighbourhood Program. So when you capture the data in the way I've described, you're inherently talking to the program at the very highest level. And then my penultimate slide is, I think this is my last one actually. And these would just give you another set of questions that you can use after your interventions that help you. If you wanted some more questions, these are other things you can ask to help show the value of your intervention in terms of whether it actually reduces GP contacts and A&E contacts. And there's some question structures you can use at the end that capture it really easily, surprisingly easily. So yeah, that's everything I wanted to chat about. Thank you for listening.
Thank you so much, Jag. A hugely comprehensive and thorough presentation. And every time I hear you speak, I just feel so much more enlightened on some of the jargon that we often hear. And it is just so helpful to have that contextualized all the way through from, as you perfectly said, that kind of translating what matters to people into what matters to the system and to commissioners. So hugely helpful to see that alignment with neighbourhood health and some really practical and quite simple tools that can be easily embedded into practice. We will share the slides with everybody that has attended and make sure that they're on our website, and some of the resources that you've mentioned there as well, Jag, will make sure goes into and we link to those in that communication as well. As mentioned, do add any questions that you've got for Jag and any of our other speakers into the Q&A function, and we'll come to these at the end. But I'm just going to hand over to Nikki now. Nikki's going to bring some of this to life in terms of how she embeds some of this within her conversations as a link worker. Nikki is a social prescribing link worker with Involve Kent, so she works at the Medway Peninsula PCN, managing 5 surgeries as a social prescriber. So an incredibly busy lady, and we're hugely grateful to hear your input today, Nikki. Over to you.
Hi, good afternoon, everyone. As said, my name's Nikki, and I'm the social prescribing link worker with Involve Kent with the Medway Peninsula PCN. So I'm just going to talk a little bit about how to embed the outcomes in the conversations that we're having with patients, and a little bit about how much I actually struggled with this at the start, and what really was a turning point actually came from a patient. Yeah, if you want to pop on to the next slide. So I think firstly, acknowledging the awkwardness of the ONS4 questions sometimes is a little bit of a potential to build further rapport with the patient. They can be awkward, and that is okay. When we're working within person-centered practice, they feel completely at odds. But why do they feel like that? So I don't think there's actually a way to discuss collecting outcome data without acknowledging that, how awkward it can feel more often than not. And as I said, it's completely fine to acknowledge this. If we didn't, the feedback that led to this webinar wouldn't exist, and we wouldn't be able to share knowledge and skills between us to find a better way to collect that data. So it is okay to acknowledge that trying to collect it can feel really unnatural at times, especially if you've sat with someone for an hour, you've done a great job at building rapport, or they've opened up to you about trauma, debt, all that kind of thing. All of a sudden asking them to rate their life satisfaction out of 10 feels completely unnatural. So when I was asked to speak today, and the subject was one of the biggest challenges that I think link workers report, which is collecting outcomes in a way that still feels person-centered. As I said, I really struggled with this when I started. It's taken me a fair amount of time to change my own thinking around outcome collection, and that is essentially what ended up helping me. I'll go to the next slide. So why do we tend to struggle with this? I don't think most link workers struggle with the questions because they don't understand them, or they don't understand why they're important. I think we struggle because we've spent years going through training, constantly learning, developing skills around listening, building rapport, having natural conversations. We're really used to following our patients' thoughts, leading them into speaking what is affecting them. And we used to be being flexible for our patients as well, whether that is, do they need to meet at a certain time due to work or childcare? Do they need to meet face-to-face or over the phone due to hearing loss? That kind of thing. So when something then feels really structured or scripted, it's quite jarring. The irony is the people that tend to find the outcome collection the hardest are the link workers who really push person-centered care. Next slide, please. So what changed my mind specifically, and how do you know your intervention or involvement worked? So about 14 months ago at a dementia cafe that I was helping to run, I was going around the tables after making a brief speech about what social prescribing is and what I can assist them with. And on one of the tables, there was an older gentleman who'd been brought by his neighbour who had dementia. He struggled with the confidence to go out on his own because of that. But if I'm honest, it was quite clear the neighbour didn't really want to be there, felt a bit uncomfortable being there, and had obviously come for his neighbour to be there for him. I'd asked if there was anything that he felt he needed help with, whether there was anything that I might be able to offer him. He was quite dismissive at first and made a few comments about how this generation were always talking about their feelings and so on. And he was honest and said, I don't think you can offer me anything. Social prescribing seems a bit strange to me. And I found myself being a little bit defensive at first. And that is purely because I know it works. So I started to list some of the things that I might be able to help him with. So feeling lonely, missing connection, feeling like you're not part of the community anymore. He looked at me and said, but how do you know it would work for me? And my immediate response was, well, because I see it every day and I see that it works. I can see someone becoming more confident, leaving the house more, reconnecting with their community. I can see someone who's less overwhelmed. And after a minute, he said to me, but that's your experience. That isn't evidence, is it? That doesn't help me. And that was the really short sentence, literally 5 words, that changed how I saw outcome data collecting, because whilst my experience and your experience matters, it's simply not enough on its own to make sure that social prescribing and link workers get to continue doing what we all know works. Go to the next slide, please. So I think one of the challenges that social prescribing still faces is that we all passionately believe in it, because we see the impact every day, but belief and evidence just aren't enough. And especially when it comes to contracts, to jobs, to presence in the community, the NHS doesn't commission services because the people who do the job think that it's valuable. The funding isn't secured because we tell people that we've had really good appointments, and contracts aren't protected because link workers know that they're making a difference. They're protected because we demonstrate impact. And that is where outcomes become really important, because every single ONS4 score contributes to a bigger picture. It is not just about one patient. It is evidence that social prescribing and link working improves well-being, and that this work deserves investment, because it actually then reduces the amount of medical appointments needed, because it increases people's physical health, because it reduces loneliness, and it decreases costs in the long run. So it's evidence that our roles absolutely have to continue to exist. So how do we make sure that link workers feel comfortable enough to be asking these questions to ensure they're being asked every time? Next slide, please. So for the first 10 months in this role, I viewed ONS4 as something separate. So I'd carry out the appointment and then I'd collect the data at the end, as if they were 2 totally separate tasks. But doing it that way actually ensured that it felt really awkward and clunky. And sometimes it would feel so awkward that I would actually avoid doing it altogether. Because I spend an hour building trust, getting them to open up, and then just suddenly switch into questionnaire mode. And it felt really bizarre. They felt it and I felt it. So that was actually leading me to not be able to prove that what I was doing worked. And at the end of the quarter, only half of my patients had data collected. So despite knowing how much I'd succeeded, there wasn't any proof of that unless you sat and went through every single note on their file, and no one's doing that. So I simply felt too awkward to ask. What changed that was viewing the appointments and the outcome as one. I don't see them as separate anymore. They are part of the same conversation. I build them into the conversation based on what they've spoken to me about. Next slide, please. So what I do now, one of the main things that helped me was stopping the search for the perfect transition, because I don't think there is one. Now I'm just really transparent. I'll explain at the start of the first appointment that at some point during the next hour, I'll ask some questions about how they're feeling day to day. I reassure them they can't answer them incorrectly. And I was really shocked at first to see that most people are actually genuinely fine with it when you explain it like that. Being honest, coupled with using what they told you during the appointment, like in these examples on the screen, help them to feel less like they're just being used for data collection and more like you're asking because it really matters for you. And as I said, one of the biggest things is finding you do not have to wait till the end of the appointment. If you're having a long conversation about how lonely someone feels because they dedicated the last 10 years of their life to caring for their mum day in, day out, then you can get through 2 of the outcomes then and there. They feel like they've lost purpose. They feel lonely. How often do you feel lonely? You've answered 2 of them there. You can absolutely work them into the questions and the conversation. And this is often the best way to make it feel person-centred. If they're talking about how poor their physical stress has been because of chronic illness, again, you can answer the question about physical health there too. You don't have to wait. Fit them in through the appointment, and it never feels awkward in my opinion. Next slide, please. I think this is the penultimate one. So what's worked for me, I don't think there's like a foolproof magic formula to making these feel more natural. Every link worker will have their own style and will work out how they feel comfortable around it. But these are the top 5 things that have helped me. So don't apologise. The minute we do that, we're telling them this is the boring bit, this is the bit we have to do, and it kind of puts down how important they are. Don't try to hide what you're doing. Again, be honest about it and explain why it's done. Work it into the conversation and let it flow naturally. If you're already talking about something that involves one of those outcomes, ask it then and there, don't wait. Finally, you can accept that sometimes there's going to be occasions where it just doesn't go like this. And that's okay too. If they're really uncomfortable and really against doing it, there is no need to push it. We can check back in a few weeks. If they're more comfortable, then we can do it. But if they choose not to take part, that is fine, and you can respect that choice and just move on. Next slide, please. So if there's one thing that I would like you to take away from today, it's that collecting outcomes and being person-centred aren't opposites. They are priorities. They aren't priorities, sorry, that have to compete. They are, in fact, both trying to achieve the same thing. I haven't had a commissioner sitting on a patient appointment. I haven't had a chief executive from the NHS sitting on an appointment to see whether social prescribing is something that should be continued or continue to fund. The outcome data is how we bring those stories into rooms that we are not in when those conversations are being had. It's how we continue to show that our care is person-centred, focused completely on what one individual needs, whilst also collecting that data and proving that. At the heart of both is a really simple question, which is, has this person's well-being improved? The only difference here is that the person-centred conversations help us to understand the story, but the outcome data helps us to demonstrate it and allow it to continue. And we need both of those to ensure that the incredibly important work we do day in, day out gets continued. Thank you.
Amazing. Thank you so much, Nikki. I'm sure that was incredibly validating for many people on the call, but also hugely encouraging. And I really appreciate your honesty in terms of the challenges that you faced when initially thinking about how to embed those in the conversations. But what you've beautifully articulated is the ability for those tools to not just be an outcome measurement tool, but actually a conversational tool that can actually be used to help you to have those conversations. And I think that's a really important takeaway. Thank you. And finally, last but by no means least, I'm handing over to Tara, who is a vascular surgeon at St Bartholomew's Hospital in London. Tara's been working on a really exciting pilot for social prescribing in secondary care, more specifically a cardiac unit. And I think it's really important to think about, as we aim to grow social prescribing among our healthcare system, what this outcome collection means in secondary care. So thank you so much, Tara, for joining us today. Over to you.
Well, thank you so much. It's been really interesting listening to all the other speakers and the experience they had. It really mimics a lot of what we've been going through as we've set up this project. If you go to the next slide, I just want to acknowledge the people who are actually doing the work in this project, and specifically the amazing social prescribers, Remy, Sean, and Ina, who are spending the days collecting the data that is so valuable to us and our learning. Next slide, please. I just thought it would be, if you can go to the one right before that, the bar graph, please. I thought it would be interesting to just put this in context, because hospital-initiated social prescribing is a little bit different than primary care social prescribing. And in our specific case, it usually comes after a patient has had a crisis. This is a graph that shows people who've had their heart attacks based on their level of deprivation. And the fact that people who are more deprived tend to present in a more acute situation and at a much younger age than people who don't. So this means that when we're collecting data about these patients, we have to consider the context in that they're probably in crisis, or at least they've come to know us through a crisis. And so there's some trauma-informed care to consider. Next slide, please. When I look at hospital-initiated social prescribing and the evaluation of it, I kind of see it in two different areas. One is the actual case finding, and the other is the case resolving, or the proper social prescribing that goes on. And in the hospital, that's where non-social prescribers tend to do the case finding. So if you go to the next slide, what we need to do is figure out who it is that we want to help and who it is that we want to steer towards our social prescribing system. And that's what I mean when I'm talking about case finding. In our case, when we set up our program looking at people who need social prescribers after a heart attack, we decided that financial instability is probably an important trigger for other life problems. And so we made the very specific decision to screen people for financial need by asking this validated question: do you have difficulty making ends meet? Certainly, the group of people that we care for and treat would be very different if, instead of asking this question, we were asking, are you lonely at the end of the month? Or do you sleep in the same place every night? So I think it's really important that when you're thinking about case finding and the people that you're going to have, how you go about screening for cases is really important. Next paragraph, please. When we ask this question at Barts, we find out that 1 in 5 patients coming through the heart attack pathway need our help and have financial difficulty. I would dare say that if we asked a loneliness question, this number might be a little bit different. And that's a decision that we made when we set up the pathway. The other thing we learn is that most of the people that we find or that get steered towards our pathway tend to be men compared with women. That has a little bit to do with the fact that there are heart attack patients, which heart attacks happen in men, but also because by asking about financial issues, especially in single income families, we may be steering towards a very different population. So if we can go on to case resolving, I'll ask you to go to the next slide. There's a lot of different things that we can learn when we actually start engaging with the patients we've screened. And we use a couple different scores. And I noticed that the previous speakers have talked a little bit about some of these. I think it's the social prescribing outcome and evaluation framework from the North London Partners in Health and Care is a brilliant piece of literature. And I would really encourage you to look at it because it really does document all this well. If you go to the next slide, One of the measurements that we use, though, is the MyCost score, which is the measure yourself concerns and well-being. And I am by no means the expert in understanding this score, but I think what we like about it and why we chose it is because it really is patient-centered. So it asks about the two most important problems and also the patient's well-being. And if we take this score both at the beginning and the end of their journey with us, we're able to notice if there's a difference or not. And to us, that was a really valuable way of understanding if we're making a difference for patients. The other tool that we use is the EQ5D. If you can go to the next score, or the next slide, sorry. And the EQ5D is a bit of a longer version of what Jag talked about, and it really talks about the quality of life for patients. And this is something that is used in secondary care quite a bit, and it's helpful in economic analysis, which is why we chose to do it. But it's quite cumbersome. You have to ask questions about mobility, self-care, usual activities, pain, discomfort, and anxiety and depression. But for us, especially in a heart attack pathway, we were trying to get people mobile again. Having a quality of life score that breaks things down and gives us a mobility score was really important. And so we found that using EQ5D took a while to get used to. I think the team felt it was awkward building it into the conversation. And I think a lot of the tips that Nikki gave were brilliant in terms of people using this for the first time. But that it's incredibly valuable if you're doing an economic analysis. If you go to the next slide, the other outcomes that we really look at is tracking the services we refer to. And we use the Northeast London common data set so that we can make sure that the services were categorized in the same way and provided tick boxes for the social prescribers to be able to collect this data. And you can see, heavily biased by the screening question that we asked, that a lot of the patients need financial support. But we were so pleased to be able to collect the fact that there was a mental health support and a physical support needed in these post-MI patients, because that's really key. The other thing that we learn, and it's something that's just really, really valuable, but a kind of a no-brainer, is collecting demographics. So not only understanding what services we're referring to and whether or not we've had an impact, but who it is that we're helping. And by understanding ethnicity and what jobs people have, we can better understand how our service is having an impact on the community. So I'll go to my last slide. Really just about evaluating hospital-initiated social prescribing. Sounds a lot like evaluating primary care social prescribing. I think it's worth keeping in mind that you're finding cases through a disease-specific realm, and our social prescribers in the program have done a really great job educating themselves about what it means to have a heart attack and about some of the pathways that people will go through for that heart attack so that they can relate better to the patients. I think patient's experience can be tracked if you're diligent and disciplined about keeping track of referrals and stuff like this. And then the impact on the healthcare system from hospital-initiated social prescribing isn't necessarily always beneficial to the hospital, but across primary care as well. And I think that's one of the things that we're really working on, trying to mold that narrative as we go forward. Thank you for the time. I hope that was helpful.
Really, really helpful. I think it's fascinating that how much impact that screening question has had in terms of being supportive of the service, but tracking it from beginning to end, but also making that data incredibly reflective of the patient experience, but also the complexity and the reality of people's lives and the support that link workers are able to provide in light of that. So thank you, Tara, and thank you to all of our speakers for all of those presentations. I'm picking up from both the chat and the Q&A that we could probably do a whole series on this topic alone, and we will certainly take that message internally and think about what more we can do to have conversations with you all about this topic. There's been quite a few questions that have come through the Q&A and the chat as well, so I'll do my best to get through most of them, and thank you to Jag, who I can see has been busying away responding to some of them. Also, just to reiterate that we will share the slides and we will share any of the resources that have been mentioned in the presentations today as part of that, so you'll be able to follow up on that once we've sent those out by the end of this week. I wonder whether I could start with a question that I think I can put to most of you, actually. And that was something that came through the chat. And this is, how do we avoid patients thinking that we're more concerned about saving the NHS money rather than because we care about them? And I think that feeds into another question that's come through of how would you send the feedback to that patient, and how do we make sure that we are translating that in a way that, yes, speaks to NHS language but speaks to patient language as well. Jag, I don't know whether you want to take that first, and then anybody else that can come in, you're very welcome to.
Yeah, I think it probably helps to humanize the person making the money or commissioning decision, because they're typically a person with, if you look at their diary, it's just meetings from people asking for cash for with different levels of evidence for different things. So it's not a, I think what I'd say to any intervention, social prescribing, any community intervention is say there's a kind of a queue of people asking for this stuff and there is no extra cash. So making a case to say, here is what I want, and here's how it will improve the whole if it's redistributed from another place, makes their life so much easier. Because it's a misnomer to think there's a place where they can reach for it and get it just on an emotional argument alone. So different people work in different ways, but this is one of the reasons why we've not moved much more resource over to things that we know in our hearts are the right things to do. So we're trying to keep the heart argument, but add in a head argument that makes it really unequivocal. So I just wouldn't fight against it too much because they are one and the same thing. Some of the questions that you've heard described today, all of them are the person benefit and the economic benefit are one and the same thing. Often in the questions that we've spoken about, you're asking the same question. So if somebody's happy in their life, they just choose a number, and that number lies in the economic argument. So I don't even see a difference in the two things really, and in doing that well.
Thanks, Jag. That's really helpful. Sarah, I wonder whether you could perhaps come in, particularly on the use of case studies in your report. And actually, it's not just some of this more quantitative data we might get from these tools do actually are required to be kind of sitting alongside those patient stories and the importance of that.
I think just in terms of how you kind of make people feel valued in telling their story, I think that might be relevant in that our report is being used. Often, the process we worked really hard to make sure the process of people telling their story was in itself a positive therapeutic tool. Which I guess is part of what you're doing as social prescribers, but we worked very hard to make sure they were comfortable in terms of telling their story, that they had control of that. And it actually has been quite empowering to be able to see their journey there, and also to be able to know that they can then help other people either access support or in some cases destigmatize some of the things that they were experiencing. And yeah, like you kind of think that you're sort of going to take, using their data despite them, but actually sometimes that experience of sharing your data, whether it's qualitative or quantitative, it can be an empowering thing and a positive thing for a person to see their progress reflected, or to see how they can contribute to supporting others. So I think that, yeah, and I think sometimes being able to give something back to them to be able to share is really important.
Thank you. Tara, Nikki, is there anything that you'd like to add to that? No pressure to at all. Tara?
No, I just think that that a lot of our patients are actually very grateful for the experience that they've gotten from the social prescribers, and I think putting it into the context that could then be an experience that other patients have is probably helpful as well.
Thanks, Tara. Okay, there's another question in here, which I think is actually really important, actually, for link workers to see the impact that their work is having themselves, which I think is, quite often forgotten in this mix. And I wonder whether any of the speakers have got any examples of how this is done. The specific question is, how can we better connect link workers and community activities for data and evaluation so that we can really know the impact of a referral, both from the individual and the provider on the ground? How can we tell that full story so that everybody in the system can see the impact of that data, not just commissioners and patients alike? Does anybody have any examples of where this has perhaps been done well?
So did you want to?
Oh.
You're on.
Jag, did you want to come in?
Yeah, yeah, this is a really tricky one. In some ways, it's a second stage question for industry, but so the simple answer is for now, what we try to do is just roll it all together. So in some of our ROI calculations, we're just explicit. We're not able to separate social prescribing from the intervention, but we'll just say, look, we'll do a before and after test with some of the questions that you've heard talked about today. And we'll just say, look, we don't know which bit it is, but here's the total benefits. That's one way to do it. The second way is to encourage providers to ask one or two of these questions themselves. So then you can start to say, okay, so here's a bunch of people who I didn't refer to anyone. Here was the change in EQ5D that Tara described, or EQ VAS or life satisfaction. And we asked the provider to ask these questions as well. And here was the change over there. So that's the second way. And then the third way is there'll be more to see here, because the data crunching method that uses the clinical data, because we've got in the clinical system we'll eventually get more data on who went where, also with systems like Joy. So we'll be able to extract out the impact of the singing group, of the walking group, but that is more complex, and it requires then we're back to kind of more robust and expensive techniques. So I'd recommend those first is at the moment just rolling it in and then asking providers to use those questions as well.
Thank you, Jag. You've just answered what was possibly a PhD level question in a really succinct way, so I massively appreciate that. We are going to have to probably come to the end of the questions, but we'll see what we can do to kind of collate some of the questions that have come through both the chat and the Q&A and make sure that we answer those in some way, shape or form in the communications that goes out. And I also just want to say thank you to those that have, the attendees of the webinar that have answered some of these questions and given their own thoughts and perspectives in the chat. That is hugely valuable. Thank you so much. So just before we finish, I just wanted to let you know that we've officially sort of launched the rest of this webinar series up until November. So all of these future topics are now live on our website and you can sign up to those. So please do share this with your networks, share it with your colleagues, share it with anybody who might be interested. They are specifically intended as learning materials for link workers, and we want to provide these for free to the workforce. And so we hope that we can reach as many people as possible to benefit from these conversations that we have through these webinars. So if you're not already, do sign up to our newsletter, and we will be able to share more details on these in the coming months. We also have a champions program, which is another way to stay in touch with what we're doing and help us to continue to raise awareness, particularly in the healthcare workforce. And the details of that are on this slide. All of that leaves me to say is just a massive thank you. Thank you all for attending, even though the weather is absolutely scorching out there. Stay cool, stay hydrated and stay safe. Thank you to all of our speakers. I can't tell you how informative and insightful and useful this has been. And as I said earlier, I think this is just the start of the conversation that we can have on this topic, and we will explore more ways that we can continue that conversation in the coming months and years. Thank you to also the NASP staff who have been working busily in the background. So Nick, Eleanor, Isabel and Audrey, who have been supporting the smooth running of this webinar. We couldn't do it without you. So thank you so much. Great. Well, have a great rest of the day, everybody. 2 minutes to go and cool down before your next meeting or have some lunch. And yeah, look forward to following up with this in the coming weeks. Thanks, everybody.